Today we're talking about hypothyroidism, the truths regarding alternative and mainstream treatments. And although I am a chiropractor and also a certified functional medicine practitioner, I'm Dr. Martin Rutherford, and Dr. Gates is a
board-certified chiropractic neurologist, as well as being a chiropractor. And we'll explain.
We do work within the framework of a team. We have kind of a team of doctors, although they're not here at this same office. We have a team of doctors that we work with on many of our cases. Well, a percentage of our cases, maybe 20, 25% of our cases, who can all be involved in dealing with the chronic pain issues we have. And thus, we are fairly conversant with the medical aspect of this care, as well as the alternative aspects, because frankly, the alternative aspects generally are far superior if they're done properly. But sometimes the thyroid is in such a condition, or there are other factors present that will require you to maybe consider a combined approach. I say that because when I do the intakes, thyroid's a little different than a lot of the others. It's way different than peripheral neuropathy or chronic fatigue. Or thyroid people have been through, now most folks that are coming in get that their lab tests may be not, my lab tests are normal, but now I know that doesn't mean anything. Or they'll say something like, yes, 5 years ago that wasn't the case. But a lot of times they're still of the framework of the model of, well, I'm taking these thyroid medications. Do you have something better, or do you have something that is an herb or a botanical? And don't get that the thyroid is the center of the metabolic universe, and as a result, everything that is involved with the metabolic universe needs to be evaluated and handled relative to the thyroid. So we're going to bring that and other things out today. I think this will be good. Full disclosure, we're going to be doing we're here in Reno, Nevada, at the foot of the beautiful Sierras, and not far from Lake Tahoe. And we're going to be doing a talk this week on thyroid. We haven't done one in about 10 months, so this is a little brush up for us. So you're going to get up to the minute data. So overview of why the thyroid is so important in chronic pain practice. Our practice is a functional neurology practice and a functional medicine practice combined, because both of those address consistently core elements of chronic pain. In coming to understand things like fibromyalgia and peripheral neuropathy, it started to become apparent that the thyroid was a big player. So why is it such a big player? Why is it so important to chronic pain? Let's go with that.
Yeah, because the genesis of this practice was really as a functional neurology practice. That's what you had gotten into 7 years ago. That's what I got into, going on 8-9 years ago. And so our focus was on treating neurological conditions like, let's say, just say depression. Not that we're here to treat only depression, but depression is something that was being looked at in terms of, could we exercise the frontal lobes, which are relatively not firing as well in a depressed state, and could we get them working better and allow a person to feel better? Another example would be, we were working with dizziness patients. As Dr. Rutherford said, we were working with peripheral neuropathy patients. Patients who have neuropathy have numbness and tingling and burning in their feet generally, and it can spread up to their hands. But the underlying current of all these neurological conditions is that frequently there's a metabolic component. And so often the thyroid is involved with these neurological conditions. So at that point, we had to kind of pump the brakes, and we had to say, okay, well, we need to understand the thyroid physiology to the nth degree so we can help someone within our modalities. And probably many of you have been out there. If you have a thyroid problem, you've either been told, you need to take medication, or, oh, it's not bad enough, you don't need medication. And really today, hopefully we're going to be able to explain the truths behind that, but also the other information that you need to know, because there's a lot of other factors that may be playing into why you don't feel well on a consistent basis.
The patient comes in here mainly because they're taking the medication, because that's the standard allopathic approach. And as I hope you got from my opening statement, we're clearly not anti-medicine. Okay. But here's what I hear. as my mentor's book was written, Dr. Karazian, why do I still have thyroid symptoms when my lab tests are normal? I'm going to the doctor. They do my TSH, my T4, my T3, and this is still happening. Not as much, but it's still happening quite a bit. And the doctor says, I'm fine. I still have all the thyroid symptoms because I looked them up on the internet, and I'm dismissed for the next 6 months. Or I'm taking my thyroid medication and my lab tests are normal. And it's all over the place. My lab tests are not normal. I'm sorry. I'm going to the doctor. My lab tests are all over the place. They're up, they're down, they're sideways. He or she's trying to dose me. I'm their worst patient. They don't know what to do with me. These are the patients that show up in here. And I suspect this is far, far, far more the norm than not out there in the thyroid world. I must admit, I'd hate to be an endocrinologist doing thyroid today based on the way that model is still being embraced in that field. So let's talk about why that is. Why is it so confusing? People will come to me and say, gee, I went to the Mayo Clinic, who, by the way, says that they need to do a national study to try to figure out how to take care of subclinical hypothyroid. You can look that up online yourself. Medical Clinic, Mayo Clinic, subclinical hypothyroid. Overview. So let's look at the anatomy and the physiology. Let's start with looking at the anatomy and the physiology of thyroid, and ultimately, by the time we're done, you're going to understand why it is really a complex issue, and it really needs to be handled by somebody who knows what they're doing. I remember an endocrinologist telling me that I shouldn't be doing thyroid because it should be handled by somebody who knows what they're doing.
That's actually, it wasn't their spouse that said that.
It was their spouse. That's true. It was their spouse that said that. And we won't even get into that any more than that. So thyroid anatomy and physiology.
Yes. The thyroid gland sits at the front part of the neck, or the base of the neck, as we commonly term, a little below the Adam's apple area and around that area. And the thyroid gland makes thyroid hormone. And thyroid hormone circulates throughout your body to increase cellular energy. Okay, so that's the first grade version. Now, taking a step forward from that with the thyroid, we know that there's a chemical that comes from the brain that sends signals to the thyroid, telling the thyroid gland to make thyroid hormone. That chemical that comes to the thyroid from the brain is called thyroid stimulating hormone, or thyrotropin. And so that's basically the gas pedal to tell the thyroid to work when thyroid hormone levels are low. And then the thyroid,
that's what you usually get measured.
Exactly, when you have a lab test. And the thyroid gland makes inactive thyroid hormone, which is called T4. T4, let's just say it this way, 93% of what the thyroid makes is T4. And then that T4 circulates throughout the body, gets largely converted at the gastrointestinal tract and the liver.
So it has to be activated somewhere.
Turned into active thyroid hormone called T3. And that T3 is the chemical in your body that really upregulates cellular metabolism. It's what gives us good cellular energy. Now, within the thyroid spectrum, we have to look at what are the symptoms of someone who has hypothyroidism. Generally, they will be fatigued. They have a tendency to be depressed. They will also have a tendency to gain weight very easily. They'll also maybe be losing their hair, especially losing the outer third of the eyebrows. We may have changes in how the eyes look in the orbits, so to speak. We can have constipation, dry skin down in the legs, and also accumulation of fluid in the lower legs. As a general example of someone with hypothyroidism, they may even have a raspy voice. So the flip side of that is someone with hyperthyroidism, where they may look like some of our favorite comedians, where their eyes are kind of bulging out of their heads.
Marty Feldman.
They may.
Well, he had Graves.
Okay.
Yeah.
They may have tachycardia. He's before my time, so that's why I was laughing with you. They may have tachycardia, where their heart is pounding, high blood pressure, diarrhea, tremulousness. That is the classic picture of someone with hyperthyroidism. And so many of you can probably associate with one of those high or low thyroid pictures. And from there, the thyroid gets more complex. But let's just first talk about the medical
But I think
approach.
that was complex enough. In other words, you have a thyroid, you have an organ that puts out hormone. That thyroid hormone does nothing until it gets to your liver, until it gets to your small intestines. So that can confuse those lab findings quite a bit. You can have a normal output of thyroid hormone. Your lab test says it's normal, but maybe you got a bad gut. And it gets more complex than that. But That's just drawing the general complexity of it. And then ultimately it has to get to your cells, and then it has to be assimilated at the cells. Something can be happening there. Stress, medications, things of that nature, that's causing that active hormone that just was formed from the inactive hormone that comes out of your thyroid. And that might be it. So for the person who comes in looking for another herb or botanical to make their thyroid work better, maybe their thyroid is already working well. Maybe it's the other things. And again, we'll draw the complexities out as we go from there. But I thought that might be just a little bit of a way to understand it before we go into the medical approach. The medical approach, which is primarily a medical approach.
And again, we're not anti-medicine. We're trying to give you the facts.
No. I'm on thyroid medication. For those of you who watch me, yes, I do have everything. I actually pulled my chart out the other day and put it on my desk a week ago because someone said, you say all that stuff, and I don't believe it. So I pulled my chart out and showed them I had H. pylori and parasites and celiac and Hashimotos. That's I have all my labs there. So I watch, I do all the things need to be done alternatively, and then I take a very unique dosing procedure of thyroid medicine. So clearly we're not, and let me tell you, I'm good. So we're not anti-medicine. Again, I'm gonna really emphasize an integrated approach on this, because in certain cases that was a breakthrough for us.
It was very much so.
So standard medical approach, though, separate from the integrated approach.
Yeah, an integrated approach, that is the breakthrough. I think that's what you need to know. That's what you need to know. That's the whole point of today's broadcast, and maybe we'll accentuate that even more as we go on. So the standard medical approach is you go into your doctor, you have signs that your TSH lots of times will be elevated. Remember, that's the hormone that comes from the brain to the thyroid, and the thyroid hormones circulate back to the brain and let the brain know how much thyroid hormone you have. So if you don't have a lot of thyroid hormone, then your TSH is going to go up because your brain is saying, come on, thyroid, do your job. So that's confusing for a lot of thyroid patients, because you think, if your TSH is high, then your thyroid's high. It's the exact opposite. So with a high TSH, a doctor is going to say, okay, well, John, you have hypothyroidism, so we're going to give you this thyroid medication. The thyroid medication is basically inactive thyroid hormone, or T4. They're commonly referred to as levothyroxine or Synthroid, depending on generic versus patented drug. And you're going to take this medication, then we're going to recheck your thyroid hormones. That's pretty much the standard therapy. And through time, most thyroid patients kind of have to have their thyroid medication dosage upped. So you may start at 25 micrograms and then build your way up to 112, just as an example. This is what a lot of our patients go through. That's pretty much the majority of thyroid patients coming in. So basically the medical doctor's job is to keep your thyroid hormone levels in the normal range. However, with the advent of the internet and popularity of it, and popularity of the books from your mentor, Why Do I Still Have Thyroid Symptoms When My Lab Tests Are Normal? There's just this huge group of thyroid patients out there who continue to feel really crummy, even though they're on thyroid medication. Or you have a lot of thyroid symptoms, but your lab tests, quote unquote, are normal also, and you're not on thyroid medication. So that's where we kind of have to start delving into explaining why you're feeling this way, which is kind of what Dr. Rutherford was talking about in terms of these other mechanisms that we're going to get into shortly. Now, what were you going to say?
I was going to say, so the medical approach is kind of trial and error, even of which drugs they use. Like they'll use Synthroid if it works, it doesn't work, or it makes your head feel like it's going to blow up. Then they'll go to levothyroxine. And so it's not like a real, okay, we have these symptoms and these findings, and we're going to give you this medication. And then ultimately, it makes sense that the dosages have to be figured out. It's nice that the dosages have to be figured out, and that it's at least acknowledged that you don't give the same dosage to, someone who's 300 pounds versus someone who's, 85 pounds or 90 pounds or something like that. And, but it is trial and error. And so if it seems like that's what's going on with you, that is what's going on with you, because that's just the way it has to be done in that model.
We have to see how your body responds to the medication.
Right.
Now, in the alternative model, that's this whole other separate field.
And this alternative model almost gives me more challenges when I'm doing the intake consults. I do the intake consults. I'm in on the exams. I'm in on evaluating and articulating the treatment programs. Dr. Gates does all treatment here and all research. I say 99% of research, but it's really 99 9/10% of research. And in the alternative folks, who I'm going to assume a lot are watching here, seem to really cling to their model of care. So let's talk about that, because it's not a, let me just say, it's not a consistently successful model.
Right. So the alternative mantra, we get it. You know, we try to do everything natural first, but we're also trying to be realistic too. So if we see something's not working, we're going to change course, so to speak.
Consistently.
Yeah.
Not working most of the time.
So relative to the alternative approach to thyroid, I mean, it started way back in the 80s with the acknowledgement that the thyroid gland basically combines iodine and hydrogen peroxide to form inactive thyroid hormone. So the big stick for a lot of years, and still even currently, we're hearing about this, is, oh, I have low thyroid, I need to take iodine. And so you may have practitioners out there who put little drops of iodine on your skin, and if your skin absorbs the iodine, then that means you're iodine deficient, so you need to take more iodine. Or, you know, we have other patients coming in here.
You put the temperature on.
We have other patients coming in here berating us to test their iodine levels, and you know, they need to take their iodine. While other patients come in saying, you know what, I watched a broadcast on PBS Saturday night, and they were saying that cruciferous vegetables are bad for me because this thyroid expert said so, and it interferes. Yeah, goitrogens interferes with how the thyroid functions.
That's from the 60s.
So that's kind of the alternative approach, and we're not meaning to completely bag it, but we're just letting you know we have not found it to be accurate. We haven't found it to work relative to the examples we just said, and we've actually seen cases, not only personally, but also there's just a tidal wave of them in the literature where people are taking iodine and they actually make themselves worse. The reason being is that, and this is going to kind of dovetail into our next point, the underlying cause of all, I can't say all, but most, a significant percentage, depending on the statistic that we want to quote, 80 to 95% of those of you out there with hypothyroidism, you have a low thyroid because your immune system is killing your thyroid gland. You actually have what's termed an autoimmune disease, where your immune system is killing you, something it's never supposed to do, but it's becoming so much more common in our society.
LabCorp says it's 95%.
And nobody knows why. Yeah, I think Mayo Clinic says it's
85%.
I think they said 80, LabCorp says 95%. And we'll get into the disparities.
Me, it's 85.
Disparities on those stats. But with that, the immune system killing the thyroid, we have to say, well, that's really the issue. And so if you're following an alternative approach where you're saying, okay, I need to take more iodine, well, what the current literature is showing is that those who take iodine, you're actually putting more iodine into the system, and the immune system is actually killing the enzyme that combines iodine and hydrogen peroxide to form thyroid hormone. So the more iodine you put in the system, lots of times it can be like fuel on the fire. Now, we're not saying that iodine has nothing to do with thyroid dysfunction. Obviously, it did back in the 1960s in the Midwest, where people are developing goiters because they had no iodine in their system. So no iodine is not a good thing. Too much iodine is not a good thing either. But enough iodine is the right thing.
And in our office, you're autoimmune until proven innocent. And it may just be our patient population. I mean, the person who comes in here is going to be the person who says, I've taken the medication, it didn't work. I've taken the medication, made my head blow off, my heart started pounding, I ended up in the hospital. I'm taking the medication and nothing happened. You have those things, you probably have Hashimotos. And if you bother to touch, anybody bothers to touch your thyroid, if you have nodules, if you have enlarged thyroid, if you have tenderness there, the chances of you having thyroid Hashimotos, an autoimmune attack on this is why we always emphasize doing an exam on the thyroid. And it's hard to palpate. It takes a skill. Some people can't do it. They won't tell you they can't do it. But the bottom line is if you have any of those things and it's not thyroid cancer, which it's not most of the time, there's a good chance that you have Hashimoto. So it's like Dr. Gates almost said, if it's not the reason for all, it's the reason for almost all hypothyroid cases. Mm-hmm. So genetic associations. So we're going to go?
Yeah, I'm going to give a little overview on Hashimoto's a little further.
Okay.
So then we have to beg the question, if you have a low thyroid and you're taking medication or you're taking your iodine and you're not really feeling that much better, what causes the immune system to kill the thyroid? And it's, as I mentioned to you before, it's becoming more and more common. We actually quoted a statistic, and I believe it was our January broadcast, saying that now almost upwards of 1 in 4 females in certain studies are being shown to have Hashimoto's thyroiditis. Now, you as a patient also
you're not
have
saying 1 in 4 thyroid females. You're saying
1 in 4 females,
human being females.
It's very, very common. There is so much confusion on this topic. I can't even, it's hard to really pinpoint where to start. But one place that we want to talk about relative to Hashimoto's is this discrepancy on what constitutes Hashimoto's and what doesn't constitute Hashimoto's. And we'll get into that relative to what constitutes hypothyroidism versus what doesn't as well. So with Hashimoto's, we're looking at an immune cell count to the thyroid. So how many immune cells is your body making to the thyroid? We can measure that. Think of them as little missiles against your thyroid. The lab value for how many immune cells is abnormal or was abnormal back 5 years ago used to be 100 for most labs. Then it went to 60, then it went to 50. LabCorp in our area still says 34. However, the hospital here, the main hospital here, as well as most labs we're seeing in California, are saying anything over 9 is abnormal. So if you read disparate literature saying, well, only 10% of females have Hashimoto's, and then I'm quoting another statistic saying that 25% of females have Hashimoto's, likely those incongruencies are due to the fact that one study is saying 34 and one study is saying 9.
And Dr. Cross, who wrote the book, Why Do I Stop Thyroid Symptoms When My Lab Tests Are Normal, has been saying 10
for a long time.
Since forever.
Mm-hmm. And that's the number we are using, and we actually now use it with more certainty now that we see that other people in the community are jumping on that kind of that bandwagon. So now with the immune system killing the thyroid at a pretty high level in a lot of people, we have to say, okay, why? And the underlying factors that are associated with Hashimoto's thyroiditis include basically a couple main things and one other factor. There's finding that there's a significant association between dietary proteins, so foods you eat, that can look like the thyroid, and then the immune system may attack those food chemicals because those little food molecules can get through your intestines where they shouldn't. That's called leaky gut syndrome. Horrible term, but that's just what it's called. And then the immune chemicals to the food can start to attack your thyroid. That came out in the journal Thyroid 2008, where they looked at the prevalence of basically gluten antibodies in thyroid patients.
Food sensitivities, food allergies.
And then they've also done studies looking at dairy proteins as an example, showing that when thyroid patients eat dairy versus when they don't eat dairy, their thyroid numbers are better. And so it's not that there's another food sensitivity with dairy. We will tell you clinically, there are probably upwards of 10 different foods that we have found to be a problem for a lot of thyroid patients, but it's all about figuring out which foods are bothering each individual patient in our experience. The other major factor associated with Hashimoto's thyroiditis is the viral connection. There were associations in the literature regarding people having herpes outbreaks on their lips, herpes labialis as it's termed, and then suddenly transitioning into hypothyroidism, and their medical doctors found that they had Hashimoto's thyroiditis. And finally, somebody did the study where they said, well, that's kind of interesting. Why don't we see if there's viruses living in the thyroid? And ultimately in 2012, they demonstrated that about 80% of Hashimoto's patients have human herpes virus 6 living in the thyroid. So now it becomes this kind of this vicious circle, so to speak. So let's say you're eating foods and you're reacting to them, they're actually getting through your intestine, your immune system is attacking them because they look like your thyroid, your immune system's attacking
Let's say your
thyroid.
Thyroid numbers are normal and nobody's bothered to run any tests to see if you have these little missiles, these little antibodies attacking your thyroid, and now you have
and so now there are
problems,
and then
food sensitivities, and
exactly, and then you have viruses living in your thyroid gland
that aren't
itself.
being checked.
And so now your immune system is in this vicious cycle, so to speak, of continually attacking your thyroid. And that's probably one of the reasons why once somebody develops a low thyroid, typically they don't come out of it and they have to keep taking medication because that underlying cause is always there. Now I need to go a little further. So in the current data that was dug up between 3:30 and 6:30 this morning, very cool studies. Dr. Rutherford always hates that I say that because I'm not trying to give myself a pat on the back, but we want to get you the good stuff. There is new data out there regarding Epstein-Barr virus, which we have seen an association with hypothyroidism. And as I said, in 2012, it came out that human herpes virus 6 was found to be a player in 80% of Hashimoto's patients. They're now finding that 80% of Hashimoto's patients have Epstein-Barr virus also hanging out in the thyroid. We've been testing our thyroid patients for Epstein-Barr virus probably for the last 4 years. And we have found it very important we are using it as a marker to kind of track viral, the immune system's recognition of viruses. And we have seen that with the reduction in the Epstein-Barr virus count, lots of times thyroid patients did better.
And what percentage of the time? Not the complex, make things complex, but
I'd say 30%
exactly.
of the ones that we work with.
So, and I'm saying this for all the alternative folks that, oh, I got Epstein-Barr virus, that's it. And we have a very logarithmic, a very organized way of going about these things. So everything is looked at once. If it's between the gut and the Epstein-Barr virus, we're going to be looking at the gut first, calm that down. And then if you're still having thyroid symptoms, then you'll look at the Epstein-Barr virus. So I was saying 20%, I'll now start saying 30%. But so that's the point. Again, I want to draw a little bit. I don't want to discourage you. I just want you to understand the complexity of this, why medication may not work, why tyrosine and iodine and those things may not work most of the time. And why now somebody might pick up on the Epstein-Barr virus out there, maybe an alternative practitioner. I'm not bagging alternative practitioners. I'm just saying this is an evolving situation, and that alternative practitioner may say, oh, I read about Epstein-Barr virus. Let's go after that. And then you get the Epstein-Barr virus treated, nothing happens. It's because you're in one of those 70%. And maybe they didn't look at your gut first. And so just to try to bring the kind of the practical aspect to the scientific aspect of it. So,
and then now there's even a new virus that's being discussed called erythrovirus that they're also seeing with Hashimoto's thyroiditis patients. So that is
just Epstein-Barr virus, right? It's not cytomegalovirus.
No, it's HHV6, Epstein-Barr virus, and now this erythrovirus.
Okay, just so they know, because I've had people come and go, no, it's Coxsackie virus too. It's internet. We're on the internet, right? I'm bagging it, but here we are on the internet.
So that is a big part of the story with Hashimoto's thyroiditis. And going even a little further, again, your immune system is never supposed to attack the thyroid gland, but this is becoming such a prevalent problem in our society. They're now showing that inflammation from the gastrointestinal tract, so we talked about foods, but inflammation from the GI tract may be creating systemic inflammation. And the thyroid gland is unique in that when there's inflammation in the body, it will actually try to attract immune cells to it to help clean it up. And so that's another theory as to why Hashimoto's is becoming so much more common, because people are generally inflamed. And we've talked in other broadcasts about the associations between the gut and inflammation. You can go watch those.
Molecular mimicry, which you kind of
hit on.
And it's just a sensitive, it's got receptor sites, I think, in every cell in the body. So it's just a really sensitive gland.
Yes, it's a sensitive gland.
So just almost anything that changes affects your thyroid, because it's dealing with your energy and your temperature. So boom, boom, something happens, tells your brain, hey, we need more thyroid hormone. It's just, a lot of theories on it. So nobody knows why for sure, is the point.
And then with that, then now they're also talking in the literature about certain biomarkers. These are things that you were using 6 years ago, interleukin 4, interleukin 10, as biomarkers for Hashimoto's, the process. These are just inflammatory immune chemicals that frankly are very expensive to run, and they're unreliable because they go up and down.
They were very unreliable, and they were more expensive than all the testing we do. They were 3 times more expensive than all the testing we do. One of those tests was 3 times more expensive than all the testing we do today put together.
Yeah. And so with this whole concept of Hashimoto's, hopefully now you can kind of understand the underlying cause of these thyroid problems, and also understand that Hashimoto's thyroiditis, independent of your thyroid hormone levels, can frequently cause many of the same symptoms as frank hypothyroidism. So you think, oh, I have a low thyroid, my thyroid hormones are low, I take thyroid replacement, I should feel all better. A lot of patients have figured out that's not necessarily the case. For some it is, but for a lot it's not. And the reason why it's not, if you're not feeling better, is because this underlying autoimmune problem is probably generating a lot of your symptoms, and can even create problems such as weight gain that they're finding. We quoted studies back in our January broadcast about that. So I feel that's the skinny on Hashimoto's. Now let's kind of move into subclinical hypothyroidism, which is an interesting area of itself also.
The article that I mentioned in the communique from the Mayo Clinic is on subclinical hypothyroidism, in which they couldn't figure out why they couldn't dose it properly. And then they just kind of inadvertently put in there that 80 or 85%.
I remember 80.
Okay, then it's probably 80 of the subclinical hypothyroid cases have antibodies against the thyroid. And they just kind of blew right by it. It's kind of like, I'm reading this going, that's the problem. I'm like, no offense to the Mayo Clinic. I mean, I don't know. All I know is we treat thyroid, and
that brings up a great point.
Mind blowing to me.
So last night,
we wonder why our endocrinologists are working the way they were. Well, the Mayo Clinic is working that way, and the Mayo Clinic says we need a national, double-blind, government-funded, multi-facility study to figure out hypothyroid. What do you think the information that our endocrinologists are working off of? It's not that they're bad doctors. I'll say this, I've said it many times. If you made it through medical school, you're no dummy. You are pretty bright. You're a pretty bright dude, as they say today. I mean, you got to get together to get through it, not just mentally, but academically and mentally together. So there's just certain models that are presented today that are stunningly behind the data, but the tools available, and that's not the correct word for the medical community to change from one model to the next, are extremely cumbersome, and it may take them 10, 15 years to take this piece of data and then finally run it through the procedures and then ultimately have it get to their people out in the field. And I think that's what's happening right now.
Yeah, I was at a talk last night from a PhD researcher on cancer, and he was giving this talk, and he was talking from Cuba, and he was discussing how,
which makes him smarter than us.
I guess so. So
that was how it was
right.
Built with you, a little marketing.
And we got a whole lecture why Cuba was very good, and I'm not disputing that for anybody out there. But within his talk, he was saying how within the cancer world, that it's exactly as you say. Somebody comes up with a compound, and then they try to get it into a clinical trial, which you're talking 6 years, and the clinical trial can take another however many years, 7 years. And then for it to receive approval, you're talking about a 15-year process. And he was really pounding on why that's so important, because we need things that are proven for, an acceptable treatment for cancer. And we don't disagree with that. But what we're saying is, minus cancer, we have some major societal pandemic problems going on here, societal and pandemic problems, between obesity, people overweight, Hashimotos thyroiditis, 1 out of 4 females having this, autoimmune disease in general. Lots of times these are lifestyle illnesses we're finding. And at least there are major lifestyle components. And with that, for us just to kind of sit on our hands and say, oh, you got hypothyroidism and lab tests are normal, I don't know, go home. We just don't feel that's acceptable with the data that's out there right now. And that's why we try to grab onto the newest data and we apply it and we see if it works. And if it doesn't work, then it's not used.
And we're fortunate. I mean, if we try something and it doesn't work, it doesn't work. Patient doesn't get worse. They just don't get
a lot of it is, fairly natural. We're not talking about life and death for the most part. So relative to subclinical hypothyroidism, most of your medical doctors were trained to treat you for hypothyroidism when your TSH, remember that hormone down to your thyroid, is really high. So the normal value for most TSHs, let's just say generally 0.45 to 4.5. Every lab can differ. Some say 0.37 to 3.7, others say 0.5 to 5.5. Most medical doctors were trained not to treat the thyroid unless the TSH is up around 7, 8, 10, right in that region, because then you're really hypothyroid. And if it's above that, then they're going to treat you too. And they're going to give you a thyroid medication. And again, use that thyroid medication to see if your lab tests come back in the normal range, see how you feel. That's the standard medical management. Now, the high value for the TSH, let's say it's 5.5 or 3.7. This value has been disputed a lot. And even in Europe now, we have a gentleman flying from China, and they're using lab values that I've seen in the literature, but I wasn't quite sure that they were employing them. They're saying 2.87 is the high value for the TSH. And a lot of alternative practitioners have said, anything at 2.8 or above or 3 and above is really hypothyroidism. So that's kind of interesting. We use this to illustrate that there's this gray area stretching from 2.8 or 3.0 up to like 7 or 8. And a lot of people, this is called subclinical hypothyroidism.
That is an enormous discrepancy.
Yeah. And lots of times if your TSH is in that range, your other thyroid hormone levels are normal. So this entity where your TSH is just a little elevated, which you have to look at it, and may not even show up as being elevated on the lab, is subclinical hypothyroidism. And that's exactly what Dr. Rutherford was saying relative to the Mayo Clinic's communique, and that there is a plethora of data out there saying these patients with subclinical hypothyroidism have a much increased chance of developing cardiovascular disease. They can have altered lipids on their blood panel, so they may have like high triglycerides, which can be associated with problems with the heart. There's also data saying, they may be associated, or this problem may be associated with depression. There's concern that this can be associated with women who have infertility. And the Mayo Clinic is trying to grasp at all this data and say, okay, what do we do? We don't really know, because one study says one thing and another study says another thing. And I even attached some studies to today's broadcast where one study said with subclinical hypothyroidism, it's important because it can be associated with infertility. And another one said, well, but it's not associated with preterm delivery, so it doesn't need to be addressed. And that creates a ton of confusion, especially for pregnant females out there, or those who want to get pregnant who are a little uncertain, because thyroid management is probably never as important as it is in pregnancy. They're even talking about now, this is really cool stuff, that those with subclinical hypothyroidism, you females out there with subclinical hypothyroidism, and it's not treated and you have a baby, they've gone back and they've looked at it, the chance that your child is going to have a lower IQ is much, much higher than a female with normal thyroid function.
So they're still clinging to a medical model, not anti-medicine. They're still clinging to an allopathic model. The problem is that we're looking at the thyroid. We're just looking at, despite the volumes and volumes of data that Dr. Gates is just skimming through here, that the gut, the liver, the immune attack, their own observations showing that 80% of these subclinical hypothyroids have attacks on the immune attack. I had the most interesting case come in not that long ago who had rheumatoid arthritis. They're not even, she had rheumatoid arthritis, and she came in because she wanted to get off the steroids because they were having some deleterious effects, but she was very, she said, Dr. Rutherford, can I ask you a question? Like, I don't want to be on these steroids because I know they're bad for me for the rest of my life. But I started taking these steroids. My hair started getting thicker, and I started losing weight. I thought I was supposed to put on weight and get puffy, and my skin got better, and my constipation went away, and my heart palpitations went away, and my anxiety got better. I said, "You have Hashimotos thyroiditis." She didn't even know she had a thyroid problem, but the immune system was being calmed down, because remember, this is an immune attack on the thyroid. Now, in the medical profession, this is where I'm just going back to the model, just being so focused on one model. But if you have any other type of autoimmune problem where immune system is attacking you, healthy tissue, they use steroids, immunosuppressant, immune globulin therapy. But for the thyroid, they don't, because it's a thyroid, and we have to manage the TSH and the T4, and yet they had inadvertently calmed the immune attack on that thyroid. And I will say that's not a good long-term solution for the thyroid. It may be for certain autoimmune problems where the trade-off is just there. I mean, yeah, you're going to have side effects, but it's going to give you a longer life, and it's going to give you a little bit, or maybe a lot, who knows, more activities. But I'm just trying again to draw out this we're not medical doctors, so I just keep trying to draw out this, that we're not being prejudiced. We're looking at this from a purely objective clinical level, and trying to explain why this is the way that it is. And so anyway, so.
Yeah, absolutely. It's very confusing. It's very confusing for a lot of people. And that's why this information needs to get out there. You need to talk to your friends about it with hypothyroidism so that they can kind of gain better ground in understanding their problems, and so that they can achieve the success that we really see on a daily basis with a lot of our thyroid patients. Because if you attend to these nuances, and we're not just saying we're special, I mean, other doctors need to start looking at it this way, then more and more patients won't be suffering with thyroid problems.
Now, we've talked a lot about the alternative in general. We've talked about, you have to look at the gut, you have to look at the immune system, you have to look at food sensitivities, you have to look at leaky gut, because all of these things are creating issues that are firing up your immune system that ultimately are attacking your thyroid. You have to look at the viruses. The viruses are there. You have to consider them. You have to be able to clinically figure out, is that virus affecting that person or not? It takes kind of an organized procedure, but it's very doable if you understand where all the pieces are. But we also work in an integrated fashion. Now we get through the gut. Now we get through the virus. Maybe we still have a way to go, like with me.
So let me describe a case like that. So let's say you're taking thyroid medication, and we see that your active thyroid hormone level is low. Keep in mind, most of you have never had this tested, because we look at thyroid labs all the time. Very rarely is the active thyroid hormone level tested, largely because insurance feels it's unnecessary, because they're going to say, if you're taking levothyroxine and Synthroid and your TSH is good and your T4 are good, then likely that T4 is going to convert to T3. So
we're done. Everybody get that? They do it because they don't want to pay for it.
Yeah. So we look at a lot of thyroid markers, about 8 to 10 on an average case. And most of that thyroid conversion, again, from inactive thyroid hormone to active, occurs in the gastrointestinal tract and the liver. And I may be working through a case, and then we see that the active thyroid hormone level isn't going up. Maybe because that enzyme in your gut is so backed up and it's had such a hard time for so long, it can't improve. This is called thyroid conversion. In other cases, it does improve, and we'll see the thyroid hormone levels just kind of kick back on, and the person's losing weight and they're feeling great. In the event that doesn't happen, maybe you need to be referred for a different medication approach. And so that's where we work with several doctors in our local area. And for those patients who come to us from other states, we'll give a call to their doctor, say, this is kind of what we're seeing, and this isn't improving. Would you consider looking at this? And frequently doctors are amenable to that. They want patients to get better.
Yeah, we haven't had any blowback. We actually, when a patient's done with their initial evaluation, we put together a pretty nice, very comprehensive report that's written in a very medical, here we are with our white jackets, right? And it put together, but in very, very medical terms that communicate to the medical community. And once the doctor sees that, and or maybe gets a call from Dr. Gates, usually they're like, whoa, these guys seem okay, and what we're doing isn't working. And we rarely get blowback from the doctor.
Right.
I mean, rarely.
Yeah, exactly. So
they get
then
the report
we have found that in that collaborative effort, and that's where I said, really, that's what's the point of today's broadcast. For most thyroid patients, in our experience, a collaborative effort and integrated effort is really where it's at. Because now we're addressing all these components. And I'll try and summarize that here in just a little bit. But then going at this active thyroid hormone, it's so important for a number of things, especially for those of you out there who can't lose weight. Just know there are studies, we attach them to the January broadcast. They've done studies with hypothyroid patients where they put you on standard T4-based therapy, levothyroxine or Synthroid, or they'll take another group and they put them on active thyroid hormone, liothyronine, or also known as Cytomel, and all of a sudden, these patients who couldn't lose weight started losing weight because they had active thyroid hormone in their system. And we're not just saying you need to go tell your doctor you need active thyroid hormone. What we're saying is you need to look at those levels, because lots of times they're not appropriate in you hypothyroid patients.
And you might want to address the patients who come in here and say, I don't want to take anything.
Exactly.
It's Nature-Throid or Armor or nothing.
Right.
Okay. Again, when we started looking at this, we had to put everything on the table. Look, folks, medicine's not bad and alternative's not good, and alternative's not bad and medicine's not. There are bits and pieces of both of these disciplines that are critical to you getting better if you have a hypo. And in the beginning, I said maybe we send 20-25% of our patients to medical. I'm talking about all of our patients. But when it comes to the thyroid, it's probably a bigger percentage of people that we send and work with as far as working integrated with their medical doctor.
Absolutely.
Because of this.
Yeah, and so we have
So
patients
talk
come
about
in.
the
Yeah.
synthetic versus.
So a
please.
lot of patients come in and say,
Even though
I
I
just
know
want to
I
take thyroid supplements, or I just want to take Armour Thyroid, as
Right.
Dr. Rutherford said, because it's natural. We haven't found that necessarily to be better. In fact, we no longer use thyroid supplements in our practice because most of our patients have Hashimoto's thyroiditis, and a significant percentage, when they take thyroid supplements, which are basically animal thyroid glands, then their immune system starts attacking that supplement as well and inflames their autoimmune response. Now, some patients do fantastic on Armour. Armour is basically animal thyroid, and it has some inactive thyroid hormone in it, mainly that, and it also has some active thyroid hormone. And so a lot of patients kind of get a boost when they take Armour.
But it's very general. It's not really specifically able to target what that patient's chemical needs are.
Right. It is general. You're right.
And it can get attacked. It just can. It does.
So it may work for you and it may not. And if it doesn't work for you, then don't be surprised, because this is the reason why.
And it's working for you. We don't know why. Just keep doing it. It's fine. Whatever works.
So now we look at this huge. So if you're watching, and we have a lot of people who watch these thyroid broadcasts. So if you're watching out there, either you think you have hypothyroidism, but your lab tests are normal, or likely you're taking thyroid medication and your lab tests are normal, but you're still having the same symptoms. Nonetheless, what you need to understand is that a few factors are underlying your misery. Most likely those factors are Hashimoto's thyroiditis. Your immune system is killing your thyroid gland. The immune inflammation from the autoimmune response is creating you either to have weight gain, it's going into your brain and causing depression, it's causing lethargy, it's maybe causing swelling throughout your body, not allowing you to lose weight and accumulate fluid.
You can actually say technically you don't have a thyroid problem.
Right, you have an autoimmune problem.
You have an autoimmune problem that's attacking your thyroid.
Exactly.
And the whole world is treating the thyroid.
The secondary effect. And the primary cause of that autoimmune problem, or the primary causes, are based in your gastrointestinal tract, between food intolerances, inflammation stemming from the gastrointestinal tract causing the thyroid to basically attract immune cells to it. Viruses living in your thyroid, as the years go on, we're learning there are more and more viruses living in the thyroid, attracting the immune system to the thyroid to perpetuate this autoimmune response. So you have the Hashimoto's factor. Then you also have subclinical hypothyroidism, where maybe your lab tests we're told that they're kind of borderline, or you're normal. Maybe you're not normal. Maybe you do need to be treated. And then the other factor is, where is your active thyroid hormone level at? Because a lot of people just don't have enough active thyroid hormone, whether they're on thyroid medication or not. And that can be affecting their overall thyroid function. So I think that's a pretty good overview. And this is
I
up
think
to
it's
date.
enough. I mean, I think we could probably talk about this for another 24 hours. And I'm not joking. The course that Dr. Karazian put together for this is 25 hours, I think, something like that. And it doesn't touch a lot of the things that we do here, because we do neurological work. This can affect your fibromyalgia, your peripheral neuropathy, your balance, your dizziness, your vertigo. Oh my God. I mean, but we needed you to understand, this is thyroid. This is thyroid in our world. I will say we get some pretty consistently successful results. It took a lot of time and a lot of trial and error to take the data from our mentors, from the research that Dr. Gates does almost like pathologically daily, to bring the understanding to why are we doing this for this patient, and that patient is getting better, this patient isn't. Oh, there's the Epstein-Barr virus, we kill it in that patient without drugs, and it makes no change, but in this person it does, and so on and so forth. So yeah, so it was very crazy getting to that point. But this is thyroid. So I go back to when I started out, and the person comes in and they say, well, I went to the thyroid, and maybe I need a different medication, or maybe there's some different herbs or botanicals. If a person has that mindset when they come in here, they're not going to be a patient here. I mean, you have 0% chance of getting your thyroid under control with a silver bullet. We have a presentation in our Hangouts that you could scroll down to. It's called "There Is No Silver Bullet." It's for chronic pain. But one last little piece of information. It is a rare chronic pain patient that comes here who doesn't have a thyroid problem. And so we felt, again, this is kind of a dry run for a couple of talks we're going to do in the next couple of weeks to a couple of audiences. But but I do think that that summarizes what they need to understand so that they can walk into their doctor's office. And, you know, you don't, I don't know, it's just so you can, it's just so you can evaluate the data better that you're being given or the recommendations. I mean, don't go in there and beat your doctors over the head with this stuff, because they have their method. They're not going to change, not because they're bad people or they're dumb. It's just they have their method. They have their model. They know what to do. Not every doctor is going to take 250 or 250 hours out of their life and go take courses on this or go take it at night. If you think that some like the Mayo Clinic or some research center is sending them communiques and updating them on all this stuff, they're not. Their model of care isn't designed to be able to do this type of work. I will add, taking care of a thyroid that is a Hashimoto's could take 3, 4, 5 months to resynchronize the immune system, get your gut fixed, make sure that that's better so that's not come back, figure out what your diet should be, get rid of your virus, all those types of things, because it takes some time. So it's a completely different model. But I'm going to tell you, this is the model that I think you're going to find is going to ultimately prevail in the long run, if we're really serious about getting people with thyroid problems better. So that's my conclusion.
I like it.
Okay.
I like it.
So hopefully that was good. Let us know what you think. You have any ideas on any topics? I keep forgetting to say something about look at what.
So if you have more questions, you can go to powerhealthtalk.com if you want more information. We can no longer facilitate questions via online
Personal
because just because
no time.
we don't have the time.
It's just
unfortunately, it became too voluminous with all the people watching across the globe. We do these talks because they're educational. We want to get the information out there. It's pretty humbling to get some of the feedback. We're getting requests from all over the globe to air our broadcasts or air our information to support groups, fibromyalgia support groups, thyroid support groups. It's pretty neat.
We do case evaluations at a fee. We've kind of put that in there and that usually entails us having you send all your data, fill out a 17-page history. We look at it, like every single bit of it. Usually takes him 3 minutes and it usually takes me an hour and a half.
No, not true.
No, it takes time, and then we usually do a consult over the phone, and then we can kind of answer your questions that way. And it's just one of those things where, like I said, we had to move to that for the people who were really motivated, because it just was crazy. He was spending at least 3 hours a week or more and seriously answering scores and scores of questions. And we do run a pretty busy practice, and we need to pay attention to the people who are here, and we need to occasionally take some time off and things of that nature.
So anyways, these videos are informational, but if that's something that you're interested in, you can look on our website. We have links for that, powerhealthtalk.com. And thank you for watching, and
see you next
we'll see you next week.
Yep.